Good morning and welcome to Trauma Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A chat and we'll be sure to ask for you. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker today, Dr. James Walker. Dr. Walker is Assistant Professor of Surgery, practicing trauma, burn, acute care surgery, and critical care at Grady Memorial Hospital. He received his medical degree from Medical College of Georgia, completed his general surgery residency at University of Texas Southwestern in Dallas, Texas, and did his fellowship in trauma and surgical critical care at Emory University School of Medicine, Grady. In addition to his clinical activities, Dr. Walker is committed to improving rural trauma and burn care in his home state of Georgia. He is actively developing rural telehealth programs and teaching rural trauma courses. Additionally, he participates in research regarding combined trauma and burn injuries. Please join me in welcoming Dr. Walker.
Awesome. Well, thank you all for having me. It's a short drive up and happy to be here. Happy to see some of the faces I recognize from y'all's residents coming down to rotate with us on burns down at Grady as well. I'll try not to bore you over an hour. I generally don't make it a full hour in these talks, so don't worry about that either. We're going to be talking about trauma and burn resuscitation, and then doing a little detour to telehealth and how we can improve your resuscitation with telehealth. And overall, no disclosures. Super happy to be up here at Northeast Georgia Medical Center. Y'all already know the importance of early resuscitation, developing whole blood in your rural centers, working with your RTAC, having blood products on multiple ambulances throughout different counties. So very impressive work. Beginning resuscitations early. And I think the more we look at resuscitation earlier is better, whether it's burn or trauma. Also, like I mentioned earlier, the partnership we're starting to develop, having y'all's residents come down and rotate with us on burns, I think can only further be strengthened through some of our clinical pathways and potentially some telehealth as well. So we're going to start by talking about burn resuscitation, how much fluid, what fluid do we use, some pitfalls, and then kind of go through the history of it, starting all the way back with the Parkland formula and getting to where we are now with modified Brooks and consensus formulas. Then we're going to talk about what happens when you add trauma to burns and how that changes the resuscitation and what that does to the morbidity and mortality for the patients. And then we're going to detour into teletrauma and burns, the history of telemedicine, how it's currently utilized in different states to improve the care of trauma and burn patients, especially in rural settings, how it improves resource utilization, and then talk a little bit about a program that we're starting up at Grady and hopefully going to be partnering with y'all on as well. So when we talk about burn injury, we really break it down into kind of two categories, local and systemic injury. Burns, less than 20% really or more at the local level. You have pain, you have swelling, you have tissue loss and inflammation at the site of injury, but it's not a big enough insult to affect the entire body system. Then we get to burns greater than 20%, your deeper burns that have an inhalational component, and that completely changes the way a patient acts and how you treat them. Then you go into a multi-system shock. The whole body has a systemic inflammatory response, and what is a local insult affects multiple organ systems and leads to multiple organ system dysfunction. So when we think about a burn injury, we classify it by its severity and by its TBSA and depth. Deeper burns, larger burns are going to have the more profound systemic shock that we have to do a more in-depth resuscitation for. As you can see with this patient on the left here, that the entire back, torso, extremities are all deeply burned, which not only compromises the immune system from the skin, temperature regulation, but also causes cardiac dysfunction, renal dysfunction, can lead to profound ARDS. So it really affects the entire patient. You have to think of the entire patient during that resuscitation. And again, just to for learners to briefly go over the different degrees of burn. Your superficial first degrees are just going to be your epidermis. That's just a sunburn. Really no need for any sort of specialized care. But as we move further along, you have your partial thickness. We look at these at a deep and a superficial partial thickness. These are your second-degree burns. You're getting into the dermis. And sometimes these will require surgery and will be calculated into our TBSA, or percent body surface area, when we're looking at burn size for resuscitation. Next, we have our third-degree burns, and these are all the way through the dermis. This is going to be your thick, leathery burns. And these are definitely going to be impacting the resuscitation of the patient. You're going to need surgery to excise these and eventual grafting because there's not any healing potential there. And lastly, you have your fourth-degree burns. These are ones you really know when you see it. The whole limb is charred, you have injury down to muscle or bone, and often these are non-salvageable, lead to amputations. So burn shock we mentioned earlier. It's a systemic inflammatory response to large burns. It's generally greater than 20%, but that's always kind of a rough number. You can have slightly smaller burns, which have an inhalational component, or in a more frail, elderly, or sick patient that needs a formal resuscitation. Or maybe slightly larger burns in a healthy, younger patient, and they're only superficial partial thickness that doesn't need a formal resuscitation. But 20% is the number we really start at, and if you find someone who's around 20%, I want you to start thinking about doing a formal resuscitation as early as possible in their burn course. The reason that they have such a profound shock is they have global dysfunction of their capillary system. They have significant capillary leak, causing edema, third spacing of tissues, intravascular hypovolemia, and shock. And this is seen throughout the body and affects all body organ systems. Burn shock really lasts 24 to 48 hours, but you're going to really see this peak at 6 to 8 hours. That's when you have your most profound capillary leak, and you have your most intense need for fluid resuscitation. So treatment. We all remember from medical school or from early days in residency, flood them with fluids, right? This capillary leak means that they need volume and lots of crystalloid. But similar to the trauma world, we've started to learn that large amounts of volume doesn't always help the patient. Increased rates of ARDS, compartment syndrome, conversion of burns to deeper levels with higher crystalloid volumes given. So what was initially flood them with as much volume as you needed to get them to urinate at about 1 ml per kg has slowly been tamed down and led to a more focused resuscitation. Which leads to the next question of what other adjuncts can we use in the resuscitation? And really what we've started to see is use of colloids and colloid rescue. And that's either going to be with FFP or albumin. I know some of the residents who've come and worked with us have seen us early in a resuscitation empirically put them on FFP drips, knowing that these patients are going to require it from their depth of burn, from their inhalational injury, from their frailty, that we don't want to get behind and have that volume overloaded with all the secondary consequences that we'll discuss. And that's the importance of an accurate resuscitation. If you under-resuscitate someone, you're under-treating shock. It doesn't matter if it's burn, hypovolemic, hemorrhagic, or septic, you're going to have poor end organ perfusion, organ failure, AKI, ischemia to the tissues, and death. If you have under-resuscitation, you're going to have conversion of burn, right? The burn tissue needs perfusion, especially if it's a partial thickness or burn, to potentially be salvageable without surgery. But under-resuscitation affects the burn and the skin as well, and areas around the burn can convert to a deeper level, requiring more significant debridement, renal congestion, and additionally worsening of the burns. So, let's see, it's frozen as well. How do we start a resuscitation? The textbook answer forever was the Parkland formula. 4 mLs per kg per TBSA over the first 24 hours, right? You gave your first half in the first 8 hours because that's when you had your most severe capillary leak, and your second half in the second 16 hours. Burns found that we were over-resuscitating people, right? That the Parkland formula was the appropriate place to start, or the appropriate place to finish, but if we started at 4 mLs per kg, we ended up way over. So there's a great trial that came out of the global war on terror called fluid begets more fluid, or the idea of fluid creep. Starting at 4 mLs per kg really meant that you got to about 6 mLs per kg per TBSA. Simplify things out, we say just divide it by 16, start your fluids there. Kids are a little smaller, they need a little more fluid, start at 3 mLs per kg. Additionally, giving them their maintenance with D5-LR on top of that. kids need the sugar. Electrical injuries are going to have a deeper burn, so we're going to look at 4 mLs per kg and really be watching for rhabdo. The important part of all these resuscitations, though, is they're dynamic, right? You're going to be watching markers of end-organ perfusion. The main one being hourly urine output. Again, textbooks traditionally said 1 ml per kg. We really shoot for 0.3 to 0.5 now. We don't want to over-resuscitate these patients. If they're making 0.5 mLs per kg an hour of urine, you're right on. If they're over that, you can come down on your fluids and continue de-resuscitating a patient accurately. The one caveat on that is being a rhabdo and an electrical injury. Again, deeper burns, deeper level of injury, more you have to be concerned of injury to the actual muscle as well. So that's when you're looking more at a 1 to 1.5 mLs per kg. Going back to the idea of rescue colloids, we understand that more fluid is bad. And as a patient fails a resuscitation, meaning that they aren't making appropriate urine, their lactate's climbing, they're on pressor despite us going up on their crystalloid, what can we use to rescue? And that's where colloids come into play. The ABRUPT trial was an observational trial that looked at colloid use in large burn centers. And they found that about hour 8 to 12, the majority of centers were giving colloids when resuscitation was failed, either FFP or albumin. And this decreased your total volume given and improved your in-to-out ratio. Just another study from Parkland, having to represent where I trained, they showed that adoption of colloid rescue, again at 8 to 12 hours, decreased total fluid administration with no changes in end-organ perfusion. And lastly, the ABRUPT 2 trial actually just came out as getting published this month, showed that starting albumin at 8 to 12 hours in a prospective manner decreased lactates, decreased IO ratios, and had improved end-organ perfusion. So early albumin or colloid rescue is going to be an important tool in your armamentarium in a failed resuscitation or in a larger burn. The question of albumin versus FFP is then asked, and that kind of debates between what camp you're in. There hasn't been any clear literature to show one side or the other, but there is a literature that FFP helps heal that glycocalyx and capillary leak. So I think that FFP is probably a more reasonable fluid as you're directly treating the capillary leak and the source of the burn shock. So now when we bring trauma into consideration, what happens to a patient? Not only do you have the insult from the burn, you also have the insult from large trauma. This may be a car accident with a fire. It could be someone in a structural damage or a house fire that also had a collapse. They're rarer, but they have profound impacts on the patient. So your initial management, it's no changing from your initial trauma management down in your trauma bay. ATLS, your primary survey, your secondary survey, your adjuncts with your FAST and your chest x-ray. Bleeding kills fast, right? You have to find out where a patient's bleeding to death and do your cavitary triage and treat that. Burns, again, kill you, but they kill you at hours 24 to 28. So you want to think, primarily think of your trauma, secondarily think of your burn. Trauma always is going to trump the burn. That doesn't mean you can't be doing things in the background to start treating the burn while you accurately resuscitate your trauma patient. You want to start your fluids at 500 cc's an hour, right? You want to, for anything over 20% TBSA. That way you're starting to have a resuscitation for the burn in the background. That doesn't mean you're going to change your trauma resuscitation or your product-based resuscitation with whole blood or component, depending on what you have. But you can start something to treat the burn in the background. You want to get an idea of the total burn size and depth. If this person, when they're in the OR with trauma, may need escharotomies or fasciotomies, so you don't run into that issue of compliance with ventilation later or secondary compartment syndrome of their extremity with a circumferential full thickness burn. Temperature control is going to be key in these patients. They've lost another layer of defense to hypothermia. So having that in the back of your mind, a warm room or bear huggers while in the operating room. And then lastly, you want to consider your survivability, futility, your goals of care. In an elderly patient who, say, has a 60% burn in addition to a large trauma, what they may be able to survive from the trauma isn't going to be survivable from a burn and trauma aspect. So having earlier palliative conversations, knowing that this is going to be a protracted course and require multiple operations on the onset versus on the offset. So starting by calculating your modified Bow score, which is the age, TBSA, and then if they have an inhalational injury, and looking at their survivability and having that all kind of working in your algorithm at the start. So looking at mortality of a combined burn and trauma, what happens? So there's a really great study from 2005. It was a National Trauma Data Bank study with around 40,000 total patients looked at. That looked at ISS and burn and what it does with mortality. We all know a highly injured patient with a large burn is going to have a high mortality. But interestingly, even if you look at ISSs in the 1 to 15 range with minor burns, they have a profound increase in their risk ratio mortality of 4. And this holds true for ISSs of 16 to 25 and then greater than 26. Combining a burn with a trauma is going to significantly increase your risk of death to that patient. And no matter really the size of the trauma in addition to the burn. TBI, looking at TBI specifically, similar data is found. If you look at a burn and a trauma with no TBI versus a burn only, you have a significantly increased risk of death. I know odds ratio 2.27. Burn with TBI versus burn only jumps it all the way up to a 4.22 odds ratio of mortality. And even if you're looking at a burn with TBI versus a burn without TBI but still with trauma, the burn and the TBI significantly increases your risk of death in these patients, 3.33 odds ratio. So burns and trauma increase risk of death. Burns and TBI even more so, likely from the fluid resuscitation needed for these burn patients affecting cerebral edema and cerebral perfusion. So similar to any sort of trauma, early resuscitation is very important. And that holds true in burns and trauma. And this is where we're going to kind of take that detour into looking at what we can be doing before a patient gets to the hospital. Either what y'all are doing with whole blood or blood products in ambulances, or telemedicine starting earlier resuscitation with partnering hospitals or outside of large burn centers or trauma centers. And telemedicine is not a completely new thing. It first started in the 1870s. The idea was published in The Lancet, and it grew throughout the 1900s. Similar to trauma, burns, and resuscitation, war is kind of the catalyst that drives all advances in this field. In World War I and early use of radio was used for healthcare on ships and helped guide patients who were injured. In the 1940s, this progressed. If we're looking in the 1950s and 60s in the space race, NASA monitored astronaut physiology remotely to help evaluate how our first astronauts were doing in space. And then it continued to grow into telestroke and some teletrauma really being developed. And that was more in the 90s and led by telestroke. So currently, telemedicine has shown that remote ICUs improve ICU and in-hospital mortality, and for centers that don't have an ICU provider in-house. Emergency medicine telemedicine has successfully been used in both stroke and myocardial infarction to treat patients before they get to the large centers. Specialty telehealth can decrease ED dwell times and help people who don't have access to ophthalmology or maxillofacial surgeons, hand surgeons or plastic surgeons get access that they didn't have previously. And it helps them follow up with these specialists. And patients like it. They don't like having to leave their home. They don't like having to drive a long area to access this care, especially if it's going to be something that doesn't need immediate intervention. So why is trauma and teleburns important? Imagine slides show up where it shows you all the trauma centers across the country, level 1 and level 2, and you can see large disparities and gaps in rural areas, especially in the southeast, the west, and the northwest. Like most things, population-wise, the Northeast has got a pretty good dispersion of trauma centers throughout their population centers. The next picture would be burn centers across the country, and they're even more sparse, especially in rural areas. This, again, being the Southeast, the West, and Midwest, where multiple states don't even have a burn center, with Iowa, Montana, Idaho, Wyoming, Alaska, all not having a burn center and having to send their patients to Washington. And this reflects in the state of Georgia. And looking at a map of our level 1 trauma centers, again, they're localized around our population densities. Atlanta, Augusta, here up in Gainesville, Macon, Savannah. But that still leaves a large population in the state of Georgia vulnerable. When you overlay this to our a population heat map of rural patients who are at risk for health inequalities, it's very similar. The areas on the map that do not have trauma centers are medically disadvantaged for lack of care. And that matters because timely access to trauma care matters, right? There's 30 million Americans who lack access to level 1 or level 2 trauma centers in a timely manner. If you look at the state of Georgia, 13.6% of our population lives in rural areas who don't have adequate access to a level 1 or even a level 2 trauma center. And because of that, these patients have a higher mortality. Direct distance and time from a trauma center increases patient mortality. As we all know, earlier resuscitation matters. That's why the work with EMS's whole blood is so important. It's having such promising results of early resuscitation. And then lastly, people are having issues with over and under triage, right? The rural centers are sending everyone that may have a trauma to these large trauma centers. So that's overburdening the trauma system, EMS, and the EDs at these trauma centers. So if you look nationally, there's a non-therapeutic transfer rate of 33 to 40%. What that means is a patient is transferred and they leave the ED within 24 to 48 hours, depending on what you quote, with no services rendered. So a transfer that eats up a hospital bed, eats up an EMS services or an ambulance in the county that may only have 1 or 2 ambulances, and moves them a patient hours away from their family to a large trauma center where they just get told, yeah, there's nothing to do for your non-displaced mandible fracture. So how can we do this better to help the patient, to help the system, and to improve access, especially as resources and financial limitations are increasing in the current medical field. So both the Georgia Trauma Systems in a 2023 report and the American College of Surgeons have had a call to action to say that telemedicine and teletrauma is going to be extremely important moving forward, and to utilize teletrauma to provide access to care, especially in rural populations who have disparities in their trauma access. So it's great that everyone wants it, but the real question is, does it work, especially in trauma and burns? We know it works in stroke, we know it works in MI, but trauma and burns is one of the more recent fields to start using telemedicine. So one of the pioneers for this is the University of Washington. They service Alaska, Montana, Idaho, Wyoming. So they have a huge catchment area for large distances and variable capability of getting their patients there at extreme cost, especially if you think you're going to move someone down from Alaska to Washington, right? So they've been really ahead of the curve on both telemedicine and teleburn. So their program has shown overall decreased short-stay admissions, decreasing that non-therapeutic transfer rate, increased rates of transfer of patients more likely to need interventions. They're finding the patients who are sicker, who need interventions, they're intervening in them and starting and assisting in their resuscitation earlier, and then changing community practice patterns, right? By partnering with local facilities, they're helping the local providers be more comfortable in managing these injuries. They're finding that they call less over time, that in burns, these local providers, whether it's Alaska, Montana, or any referral center, are more comfortable managing these patients locally and decreasing the overall rate of need to move patients to Seattle. University of Washington was really one of the first to start this telemedicine and teleburn program, but it's been replicated over multiple centers across the country. Colorado, Iowa, different California centers all have very strong programs, and they've all repeatedly been able to show that it can safely be implemented. Burn accuracy evaluation is accurate in a telemedicine platform. Visually, we're able to accurately estimate a TBSA and start a resuscitation. It's successful in down triaging patients as well, keeping patients who don't need to come in locally and avoiding that non-therapeutic transfer. And it saves costs to the healthcare system, which, as we move forward in our current timeline, is going to be a very important thing. Trauma telemedicine actually started to come after burn telemedicine, right? And again, it was pioneered by rural centers in the Southeast and the West. The University of Mississippi showed that 100% of patients who were previously transferred dropped to 11%, and with 61% of these patients being discharged home from the rural center. Again, identifying that same theme of identifying patients who don't need to come. They also, similar to Washington, found that sicker patients receiving more blood product were the ones who were transferred. They got their blood product earlier, and they didn't have changes in outcome by implementing this telemedicine program. So we're identifying patients that need to be transferred, we're optimizing the system, and we're saving costs doing it. You can see significant cost savings. And this was replicated, and this is actually up in Massachusetts, so even showing it works in the Northeast. But what was interesting about this program is they included TBI and intracranial hemorrhage, which previously had been held out. We all know with our lower mechanism, TBI is a big 1 or a big 2, your rate of conversion is low, and you can safely watch a patient for 6 hours, discharge them with a big 1, or watch them for 24 hours with a big 2, and you don't need to re-image them. But in your rural center saying, hey, watch that head bleed, you don't need to send them here, is very nerve-wracking to these patient people, to these providers, as they don't have neurosurgery coverage, and a change in neuroexam can be devastating for the patient. But Massachusetts showed that, similar to the brain injury guideline data, lower severity TBIs can safely be monitored and be included in telemedicine programs. So the benefits: cost savings, around $2,000 per patient encounter with traumatic brain injury. In Iowa, they looked at 1,175 transfers, and telemedicine was saving around $4,000 a patient, which is seen both by the health system and by the patient themselves. And that included the cost of the telemedicine program, so the development, the staffing, and the cost to both the receiving center and the transfer center. When you're looking at the patients, you have increased patient satisfaction. They like being cared for in their local facility. They like being closer to family. They don't like being transferred farther away. They don't have to find health or care for their children. Family members don't miss work. Like we said, decreased cost of the patient and the system. I think it's very interesting that it's been repeatedly shown that at your referring centers, developing telemedicine programs in specific areas increase the provider comfort. Through education from the referring center, repeated treatment, these providers become more comfortable in managing something like a smaller non-transferable burn, facial fracture that doesn't need a face surgeon. And over time, interestingly, Washington has shown that they stop calling. They know that they can just place a follow-up request in with these facilities. So you're fostering provider comfort at these rural centers and really allowing them to develop as well. You have improved access to care. We showed the importance of the rural maps and the medically disadvantaged. And you have improved resource utilization. In the state of Georgia, multiple counties only have 1 to 2 ambulances. Imagine taking 1 ambulance out for someone who has a 10% burn, who does not need to be transferred, and then they have 2 MIs in Oconee County, or Hancock County, where my grandparents live. One of them is not going to make it to the hospital, right? So in these resource-strapped and resource-limited counties, really optimizing how we use our EMS providers is very important. And then also in disaster management, and now in the whole idea of large-scale combat operations, or if a large war happened, telemedicine is going to be extremely important in helping triage who comes to large centers and assisting in caring for patients at the more rural centers with the expertise of yourselves or Grady or other level 1 trauma centers or ABA burn centers. So what are we doing for it at Grady? And this is a shameless plug of a program we're building that would love to incorporate y'all as well. So we noticed that, similar to national average, Grady has a 37% rate of non-therapeutic transfers. We all have increased ED dwell times. We all know the strain that our ED providers and our trauma centers are facing right now, especially from medical legal standpoints, as non-trauma centers see trauma and they just want to move a patient to the trauma center. This is especially true in specialty areas such as face, optho, hand, where care is more and more being localized in large urban centers. So we're starting a pilot program, which we're calling the Local Care Pathway. It's starting with burns and ophthalmology, but we're going to be expanding into other injury mechanisms, including face, low mechanism trauma like isolated rib fractures, hand injuries, or non-op ortho, and helping partner with local institutions where we empower the local partnering providers to say, you're right, I know this doesn't need to be transferred, I just want some trauma center stamp of approval. And through the use of telemedicine, Care Everywhere, Epic, we're able to have back and forth communication where we can help evaluate the injury, provide documentation and follow-up and basic injury mechanism and discharge care plans. And then we're able to QI and PI the process and ensure it works, right? Because we want to make sure we're taking the best care possible of these patients. So as that goes live over the next month or two, we'll be able to have more updates for you. Sorry for the kind of mismatch of technical difficulties, and I told you I promised I wouldn't take over an hour, but happy to answer any questions we have going through this.
Thank you. I'll remind you, if you're viewing online and have a question, please enter it in the Q&A chat and we'll ask for you. But in the room, any questions or comments?
Thank you for the presentation. So East did a podcast about this a couple years ago regarding the referral of burn patients, and
Right.
kind of the mantra was that technically every trauma surgeon is a burn surgeon at some point. So what percent, obviously I know we had a slide difficulty, but we often get patients who have, gas burns or exhaust burns from motorcycle accidents with a very small body surface area, percentage. We often keep those patients. So what are you guys saying as far as, hey, this patient should stay at your facility, or is that with the telemedicine consult? Like, are you getting telephone calls now saying, okay, if it's like just a 3-4% on the leg, keep it?
Yeah, so I think it's very variable from center to center, right? Yeah, I agree that the baseline, all trauma surgeons can do some minor burn. Your larger burns are where you really need the expertise of a center. It's not just the surgeon, it's the nursing care, it's the PTOT, it's child life, it's everything that comes into being an ABA center. So obviously anything over 20%, 15% in peds, we'd recommend moving. When you look at ABA criteria, around 10%, TBSA starts getting to being that number. But again, that can be influenced by depth, by location, by comorbidity. So by using telemedicine programs or this local care pathway that we have, we can help evaluate and look at the pictures and say, you're right, that's a 10% burn. We don't need to move them emergently using an ambulance. But why don't we have them come see us in clinic tomorrow? We can admit them if they need surgery. We can give you back documentation saying, this is how you follow up in Grady. This is wound care recommendations for the patient and for the local provider on how to manage this smaller burn until they get there. For y'all, it may be you're comfortable taking care of and grafting up to 10% or whatever your providers are comfortable with. And I don't think that those necessarily would have to move, where other smaller, more rural centers who have a general surgeon say, I want to move everything. So I think where we stand is call as much as you want. It doesn't hurt to call for a 4% and talk with us and we can say, keep it. Or, and we're obviously happy to take whatever, but I think the answer is it's really variable by what the center provides. A level 1 like y'all is going to be very different than a level 4 who has a general surgeon on an hour-long call away. And I think that's the nice thing about these teleprograms is it can be tailored to the institution.
And can you also describe, I guess, the staffing model as far as what telemedicine, is this like the backup surgeon taking the call, or do you dedicate a person for teleconsults? Like, what does Mississippi and Washington, and what are these other programs doing?
So it's very variable from state to state. If you look at West Virginia, Dr. Wilson has one of the strongest models where they bill for all of their consults. Because West Virginia has a strong region or localized trauma system, they're already credentialed at all of the other trauma centers from their main spoke, and they're able to provide a real consult. Here, and Georgia's kind of has a very broken up trauma system, all of our providers can't credential at every other center. So the model we're using is more of an empowering of local providers to make a diagnosis, and we say we're agreeing with you, and we'll accept any sort of transfer. But once you make a diagnosis of, say, that 5% burn, you talk with our on-call burn provider. They field all of the calls. So if I'm on call, whenever the transfer center calls, they call me. And this is true for our trauma providers as well, the on-call trauma surgeon in-house. Or if they're busy, the backup trauma surgeon would field those calls. And then they help navigate our criteria of acceptable things that can be kept locally or not. So it's with the on-call surgeon who would be accepting that patient. Nobody else is asking questions. I appreciate it.
I do have a kind of a technical issue with the telemedicine. So we're implemented some telemedicine for brain injury guidelines
Yeah.
locally as well. And number one, it requires us to be at a physical computer and somehow log into the official hospital Zoom. Otherwise, there's an issue with patient confidentiality. And then at the other facility, that machine has to be working. And the combination of those things ends up to technical difficulties like today. And it can be frustrating, to say the least, when you're on call and you have operations to do and a lot of other things. So how does that process work? Is there a way to just do pictures, and are those photos, sent with patient-protected information?
Yeah, so we are leveraging Care Everywhere through Epic right now. Photos can be directly uploaded. Any institution that we're partnering with is going to have an automatic setup through the transfer center where as soon as that transfer request is sent, the Care Everywhere link's established, so photos can be uploaded. Imaging can be uploaded. Through regional packs, you can additionally see imaging. I think part of the key is you have to trust your partners or your partnering institutions to make that diagnosis, to do the patient evaluation, especially if you're not providing. I think this kind of goes into is this a formal consult in which you're billing for, and you're evaluating the patient over a HIPAA-compliant video source, or are you providing a guideline-based care like what we're doing, where we're relying on the local provider to make a diagnosis and we're agreeing with that diagnosis? A lot of that goes back to credentialing and the kind of level of service provided. I know, for example, in Washington, they're not credentialing at every single facility. They're getting pictures sent to them through a HIPAA-compliant platform. And before the conference ever happens, the transfer center ensures that those pictures are visible for the on-call physician. So I think a lot of it is front-end work with your transfer center of ensuring that that link is strong or the pictures are there, and you aren't talking back and forth with the referring provider of, hey, can you put these pictures up and call me back? Because like you're saying, when you're on call at night, you're busy. And if it's not streamlined and easy to use for both the referring provider and for the provider at the receiving center, it's not going to get used.
Thank you for the presentation. I'm one of the PGY ones. We have a couple other PGY ones here. We're going to be rotating with you next year. What's the best way we could prepare for the rotation and get the most out of it?
Awesome question. We love having y'all. Hopefully y'all are enjoying the rotation and always happy to make any adjustments as need be. I think that the best way to prepare would be to look at, if you go on the ABA website, ABA, American Burn Association, and look at their generalized guidelines. We're now basically all following consensus formula in resuscitation. And it has a great section that kind of breaks down burn care for non-burn centers. And I think that's a really good place to start. Once you get there, you have a day one lecture that myself or one of my partners will give you that goes through head to toes of initiation of burn care. We'll do multiple sims while y'all are there, and I promise you'll see plenty of volume. So it's really a drink from a water hose.
Are there any special considerations, especially for this program, with pediatric burns and working with CHOA?
Yeah, so CHOA actually doesn't take any burns. All of the pediatric burns come to us. So we're both a pediatric and a adult burn center. We take all age pediatric patients from 1 day old up. We have a pediatric critical care attending who rounds with us every day. So we have a really holistic care to pediatric patients. We have additionally child life services. So as part of our kind of total burn care, we take care of pediatric patients. Partnering with CHOA and having CHOA PICU attendings round with us at Grady to ensure that these kids are getting the best possible care. So call us for all your burn needs. Awesome. Well, thank you all so much for having me.